Hello, everyone. Welcome to our session where we'll be discussing plasma, as well, we'll be discussing preventing and managing post-transplant risk of cancer. My name is Hilaria Sumo. I'm the chair of WSH-BME Kidney Network. We are a Black kidney charity providing advice, support, education, and advocacy services to Black kidney patients and their families who find it hard to navigate the healthcare and government systems. We also raise awareness about organ donation in the Black community, asking people to sign up to the organ donation register. Our educational sessions are based on issues that kidney disease and transplant patients experience, and we ask medical professionals to demystify important issues on kidney disease and transplant. So today we have Dr. Joyce Popoola, who is a consultant nephrologist and lead transplant physician at St. George's University Hospital's NHS Foundation Trust. Some of you would know her, I'm sure. She's worked in various institutions and organizations across the UK and internationally. Her work has provided her with the opportunity to work collaboratively, both nationally and internationally. We'll be talking about preventing and or managing post-transplant risk of cancer. She will tell you more about herself and what she does. So welcome, Dr. Joyce, and thank you for your input today. So to start off, risk of cancer in renal transplantation. What does this entail? Please, can you clarify for people who are listening right now? Thank you.
Okay. Well, thank you very much for that introduction, Hilary. So I'm opening a topic that might be very sensitive to many of you, the big C, cancer. And I'm sure there are some of you in the talk that might have had cancer before, might even be dealing with cancer, or perhaps may develop cancer in the future. I don't want you to get distracted by this room. It's clearly the children's room, but they've got the best computer. But let's focus on the topic we have at hand. So why are we talking with this particular group? Because many of you will be transplant recipients. Some of you might have had kidneys, or it might be other organs, and the process is more or less the same. But the fact is that you've had a solid organ transplant. But why have a transplant? Because it gives the best quality of life. When we say best quality of life, well, what's the alternative? If an individual has got kidney failure, it means they're either going to have hemodialysis, peritoneal dialysis, or what we call conservative management or supportive care. But that means that if they're not having any renal replacement, then at some point they're going to die from their kidney failure. Well, it's fortunate that back in 1954, the first successful transplant done between twins was done in the United States. Now, doing this transplant afforded a twin who may probably have died back in those days the opportunity of a life and to live an independent life. But what was the downside? And why was it only in twins that we managed to get successful transplants? Well, it's because with identical twins, they've got identical immune systems. Most people don't have an identical twin. So that means that in order to get a transplant, they're going to need something to overcome their immune system. So what does that mean? It means that once an individual has a transplant, they need to take immunosuppression for as long as they want that transplant to last. What's the downside of immunosuppression? Well, let's start with the upside. Because of immunosuppression, nowadays, I'd say majority of people that get their transplant, unless perhaps there are other factors, maybe something happens early on in the post-operative period, or maybe they've got a condition that can come back in the kidney, or maybe for some reason they've missed out on their medication. We're talking about an average lifespan of a deceased donor transplant at a minimum about 10 years. and a live donor transplant at a minimum of 15 years. And I'd like to say that the oldest kidney transplant I look after is well over 50 years old. So that tells you that these transplants can last long. But what's the downside of that? The fact that an individual has to keep taking immunosuppression. And what's the problem with taking immunosuppression? It means that not only are our systems suppressed in order to accept the kidney and prevent rejection, but we're also going to be left open to things such as infection and, I'm afraid, cancer as well. So is it inevitable that if a person has a transplant and is on immunosuppression that they'll get cancer? The answer is a resounding no, but there will be a proportion that do develop cancer. I'll just take a step back from that. When we're talking about cancer in individuals with transplants, some people might have even had cancer that led them to go on to get a transplant. For instance, they might have had cancer in their own kidneys or cancer somewhere else, and then had to let that cancer be settled or at least in remission before going on to get a kidney transplant. So that's one scenario. And one of the reasons we're quite hesitant about rushing in with a further transplant is because we know that we're suppressing the immune system, and there is that chance that previous cancer can rear its head again, and hence the reason for monitoring very carefully in the post-transplant period. And then there's the scenario of cancer developing after a transplant. And maybe for the most part, in the absence of questions, that's where we'll apply most of our focus this afternoon. So cancers post-transplant. Now, sometimes these can occur quite early on. And I'm sharing with you quite openly, but I do want you to feel free that you can ask questions. And I also want you to be aware that it's not the norm for everyone, because remember, cancer, although it is commoner in the transplant recipients compared to the normal population, if you look at the entire population of people transplanted, the majority of people will not develop cancer. So let's talk about post-transplant cancer. In the first instance, well, what kind of cancers are we talking about? It could be virtually any form of cancer, but we do know that there are some particular cancers that are more common in transplant recipients. Let's think about, why do people develop cancer in the first instance? Well, it's partly because, as in the normal population, it can be in part due to the environment that they've grown up. What's been their exposure to toxins? I mean, a self-induced toxin could be something such as smoking or alcohol. Toxins that perhaps people don't entirely have control over could be the environment that they've grown up in. Perhaps there are a lot of fumes there. Perhaps they've been exposed to some various chemicals, industrial chemicals. Perhaps they've been exposed to some forms of dyes. So already these can cause a propensity towards cancer. So the environment, self-induced toxins as a result of lifestyle. But apart from that, some people have a genetic predisposition to cancer. People might, if they look through their family tree, they might find that, oh, actually, my father or my great-grandfather happened to have a cancer of a particular organ, and then perhaps a future offspring ends up with a similar cancer. So there can be a genetic predisposition to cancers. Also, there are some conditions that people have that actually have an association with cancer, and this is partly in keeping with genetic constitution. So beyond environment, beyond genetic, beyond lifestyle, what else are we talking about? Well, you could have the combination of those things, or maybe one of those things, and then on top of that, there might be, for some reason, an issue with one's immune system. What are some of the things that can be acquired later that can cause those propensities? Some examples are viruses. And some of you might have heard of, especially if you've already been through your transplant workup and have got a transplant, you might have noted that during the workup process, we were doing multiple tests. For instance, looking for viruses like Epstein-Barr virus, hepatitis B, hepatitis C, HPV. And the reason being is because not only do we want to treat viruses if we can, but we know that some of them in themselves can predispose individuals to cancer. For instance, the hepatitis B and C can predispose people to cancer of the liver, while a virus such as human papillomavirus or HPV, which is sexually transmitted, can predispose people to cervical cancer. There are other bacteria like Helicobacter has been associated with cancer of the gut, of the stomach. So this is part of the reason why there's so much rigorous testing in the pre-transplant period. And then moving on from there, so we've talked about genetics, environment, toxins, infections. But then what is it that every single person who's got a transplant has in common? It's the fact that they're on immunosuppression. Now we know that immunosuppression can predispose people to cancer, particularly if there are other factors that are all working in concert. But what has happened with immunosuppression, and I'm going to take you back, say 60, 50 years ago, immunosuppression was very different from what we have today. Back in the day, because the medications wasn't so sophisticated, the medicine wasn't so sophisticated, people used to use much more immunosuppression, much higher doses. Steroids, for instance, people would be on very high dose steroids for sometimes months on ends, even up to years. Some people would have to go through what we call a form of irradiation. The doses of the medications would be much higher. But over time, we found that actually, in order to overcome rejection, we don't need to use such high doses. And most of the centres, particularly around the UK, will use the minimum immunosuppressant possible. It's almost the immunosuppressant is tailored to you as individuals. So going back to the immunosuppression, despite all that, we know that it still predisposes people to malignancy because it's modulating the immune system. Now, the immune system in general, what it does is it's proactive in searching for infection and also in searching for abnormal cells, getting rid of them and discharging them from the body. And sometimes it can't completely discharge them from the body, but it cloisters them such that the rest of the body is protected. Now, if for some reason the immune system breaks down, then you get a process that the cycle of those cells that are potentially cancerous is left unchecked. The cancerous cells start to multiply, and if they're not got rid of or detected early on, or changes aren't made, they get to such a point that they form the cancer. And I bring in a point here. This is why if you're an individual that has got a renal transplant, think of it, you sign up for a kidney transplant, you're signing up for immunosuppression, but you're also signing up to remain under the regular follow-up of your transplant team. And for most people, even when you get further down the line, expect that this will be at least every 3 to 4 months, at the very minimum 6 monthly. But in our own unit, we try to make sure that everybody stays under follow-up every 3 months. Is this just to smile and say hello? Is it because there's any added benefit to the NHS? Well, actually, in a way, there is. Because we know that if we keep people under surveillance, if we're monitoring, and if we're doing the appropriate checks, often a time we can pick any of these complications before they become a big problem that can't be dealt with. And that's the whole big reason why we do the surveillance or the monitoring or the clinic checkups. In fact, I think it's an advantage because I would say that most of the patients I look at or look after, they tell me that they're actually more healthy than their contemporaries who don't have any form of kidney disease because they know how to take care of themselves and they get regular checkups. Let's get down to some more specific details. So, which cancers are more common in individuals with transplants? Well, there are some particular kinds of cancer, and the one that I'm going to start with is skin cancer. Without a shadow of doubt, whether an individual is black, white, yellow, or whatever color, having a transplant and being on immunosuppression will predispose them to skin changes. Part of the reason is that one of the medications is that all of them, but some perhaps a little more than others. Some of you may have heard the names tacrolimus, cyclosporin, azathioprine. Well, they actually affect molecules within the cells, and particularly they affect the cells that are rapidly turning over. And these include the cells like the cells on the skin, the hair. Like some of you, when you first had your transplant, you may have noted that you lost hair, but after some time, it comes back again. Similarly, the lining of the gut, the lining of the bladder. But skin cancer is probably the most common cancer that individuals with transplants get. So there are different types of skin cancer, and I'll mention 2 types, although there are others. There's one called basal cell carcinoma, or we call it also rodent cell carcinoma. Doesn't look pleasant, and it looks like quite a nasty ulcer that never seems to heal. Can start as a scab and then goes on to an ulceration, which if left unchecked can get larger and larger. But the thing about this kind of skin cancer is it doesn't spread internally. Whereas another kind of cancer affecting the skin, squamous cell carcinoma, can spread internally. And that's why another thing that one will need as a transplant patient is regular checkups of the skin with your transplant specialist and potentially with a dermatologist as well. But let's hold up a little bit, because it's one thing talking about after the event has happened, but then what can we do to prevent these skin cancers in the first instance? I realize that the majority of the people on this call are actually of ethnic minorities. Probably many of you are black. Many black people have grown up with the idea that their skin is invincible to sun damage. Black people can get sunburnt. Black people can get skin cancer. Black people can get sun damage of their skin. And so the prevention is for everyone. First of all, avoiding sunbathing. I know in days of old, some people would put oil on their skin and then lay out in the sun and get as dark as possible. That's not good for anyone. And actually, as a result of that, the incidence of skin cancer increased in the general population. But what else can we do? Don't go out in the sun and sunbathe unnecessarily. Protect the skin. And how can we do that? If we don't take anything away from this session, please take away, use sunscreen, ideally factor 50, on a daily basis. And why is this? Because this is one of the things that we found, and myself and others have done quite a lot of work in this area, that those patients that do this, they have less skin damage. They have less basal cell carcinomas and certainly less squamous cell carcinomas. There are some other skin cancers like melanoma, and that's the kind of cancer that Bob Marley developed, and he developed it on the sole of his foot, and it subsequently spread to his brain. Although sun damage does cause that or predisposes to that, often at time there's a genetic factor as well. Though it's slightly more common in individuals with cancer, the two skin cancers that are most common are the two that I mentioned to you beforehand. Early detection, prevention are really the keys. Other cancers that occur perhaps more commonly in people who are on immunosuppression. There's one I do need to mention to you, and it's called lymphoma. It would probably have been mentioned to you during the pre-transplant workup, and also probably when you came in for your transplant initially. And then after that, there's often silence, unless you're one of those who unfortunately develop this. And it's called lymphoma. In the case of a transplant, we call it post-transplant lymphoproliferative disease, or PTLD for short. So it's a form of lymphoma. And some of you might know people who've had lymphomas or have heard it on the television in the community. What is it? Well, it is a kind of cancer, but it predominantly affects the white blood cells, so different from the cells involved in sickle cell, the red blood cells. Here we're talking about the white blood cells. But it also affects the glands, as in the lymph node glands. And whenever you get a sore throat or you don't feel too well, often the glands swell up, and they can be found in the neck, the armpits, the groins, etc. Now, the lymph glands are very important for fighting infection, but also for fighting cancer. So if they then develop a cancer, which is what lymphoma is, a cancer of the white cells and the glands, but it also affects the spleen as well, that's not good, because clearly the person's not going to be more predisposed to infection. If it's left unchecked, they could actually die from that. But the thing about the lymphoma that develops in association with transplantation or immunosuppression is that often a time it's more readily treatable than the lymphoma that develops outside of this scenario. Sometimes it's just a matter of, for this particular individual, what we need to do is reduce the amount of immunosuppression they're on. Admittedly, by doing that, because it's like a weighing scale, you reduce one, and then there's more predisposition to possible rejection. But then at the end of the day, all of you are more important as individuals than your transplants. Although, yes, it does have a major impact on quality of life. But most of us clinicians, in discussion with you, will take it that you are the most important. And so it's getting that balance between rejection and the transplant. often a time, actually, just by reducing the immunosuppression and not getting to the point of rejection, the lymphoma will dampen down and settle down, but then it does need to be monitored. And there are some people that have a virus called the Epstein-Barr virus that can predispose them more to this lymphoma, particularly if they acquire it later. So Epstein-Barr virus is the same virus that causes mumps or the kissing disease. So it's usually better to get that in childhood than get it later in adulthood. So still focusing on lymphoma. So some people need further treatment and some people actually need chemotherapy. But often the time, and in fact, most of the patients that I've looked after that have had this condition, they've gone into remission. But it is important to know, and on average we quote, at least in the UK, somewhere between 0.5 to about 2 to 3% may develop this condition, but it's usually possible to get it into remission. In the United States, they quote higher, but they often use more immunosuppressants than what we do in Europe, and particularly in the UK. Some other cancers I'd like to mention, although it's not necessarily because people are on immunosuppression that they're developing this cancer, but they can nonetheless. One of them is kidney cancer. So some of you may have had kidney cancer going into the transplant, and that requires ongoing monitoring and surveillance in the post-transplant period. Some may have developed it, or it may have just been detected, say for instance in their native kidneys, post-transplant. And some individuals may develop it within the transplanted organ. Now it's difficult to say because it may be, in some instances, this may be because maybe those cancerous cells came with the kidney that was donated. Not common, but clearly it could happen for similar reasons to some of us have cancerous cells in our organs that our immune systems are balancing and keeping at bay. But because when we have a transplant, we have to go on to immunosuppression, this can flare. But that's the reason for the monitoring post-transplant. And it's also the reason why sometimes some people will come up to the hospital and say, oh yes, I've got my transplant. They find themselves waiting for hours on end, only to be told, well, I'm sorry, but the transplant can't go ahead. It might be because actually there was a change noted in that organ that we felt it's safer not to transplant it into someone else. But let's talk about cancer developing post-transplant, be it in the organ, be it somewhere else in association with the kidneys. Sometimes it's small enough or located in a position where it can be resected and removed and the individual continues with their transplant, but under surveillance. Recently, I looked after someone who unfortunately had to have their kidney taken out. But this isn't the end of the road, because what will happen is, yes, the person would need to have dialysis for a period, but after a while, and it will vary, it could be anywhere between 2 to 5 years with surveillance monitoring and depending on the situation, making sure the cancerous cells are all gone, then there may be an opportunity for a future transplant. Some other cancers I'll mention, cervical cancer. So I'm sure there are some women in the talk. Cervical cancer if you note, all of us are expected to have cervical surveillance. This is in the form of smears, sometimes there's a biopsy, but nonetheless, everyone is expected to sign up to surveillance for cervical cancer. Now, because of this surveillance, the incidence of cervical cancer in the UK has come down rapidly and come down to an extreme, such that it's not common to hear of people dying of cervical cancer because it's usually detected early. Now, there is an issue though. If people don't do their surveillance and they're on immunosuppression, then they could get more florid and more rapidly developing cells. So it is important to continue that same surveillance that one would have had even without a transplant, and perhaps all the more so. So the frequency doesn't necessarily need to change, but it should happen still. Another thing is, for the younger ones, there's a virus that we know seems to predispose to cervical cancer, and it's called human papillomavirus, or HPV. Fortunately, there's now a vaccine, and for those of us that have children who've been around the ages of 12, 13 in the past, say 7 to 10 years, they would have been offered this vaccine. And this is something that seems to be helping reduce the incidence of cervical cancer. So for the younger ones among us, so that's one opportunity, preventing that virus which can predispose to cervical cancer, but also ensuring regular surveillance. And then breast cancer is another cancer I do want to mention. Breast cancer isn't necessarily caused by the immunosuppression, but being on immunosuppression doesn't necessarily help it, because the immune system is suppressed. So those active surveillance activities that the body would normally have performed, the ability to overcome and curtail is somewhat reduced. And so hence, I emphasize this because once again, we have an opportunity here in terms of getting regular mammograms. Not a very comfortable test to be done, but it's something that's offered in the UK. So I would encourage people to get that done because early detection of breast cancer is paramount. It's very rare to see individuals with what we call spread or metastatic breast cancer. But when it does happen, it's devastating, and to us clinicians as well, because often it's preventable just through surveillance. There's some other cancers that we probably have heard of. We might have heard of people having cancer of the stomach, the colon, different areas. These aren't necessarily as a result of the immunosuppression, but they could perhaps spread more rapidly because of the immunosuppression. But once again, if we think about what does the NHS offer in terms of surveillance for cancer, there's opportunity for surveillance for breast cancer, cervical cancer, prostate cancer. That's a shout out to the men in the room. And I'm afraid, unfortunately, prostate cancer is more common in black men. I don't know why, but this is what just happens. And it seems to be more aggressive, whether it's because they're presenting later or whether there's some genetic predisposition. But prostate disease is much more common in black men and seems to present at a more aggressive stage. But then for those of the gentlemen in this room, because you'll be getting your active surveillance, hopefully that won't happen to you. Other cancers that the NHS offers screening for include for bowel cancer. Now, the test for this, it's not really a pleasant test to do, in that you actually have to get a stool sample and you have to put it on a slider, like a sort of like a small tube, etc. So it is a bit messy because most of us don't fancy touching our feces. But if we think of the opportunity here in detecting bowel cancer early, I think it's a worthwhile test to do. Now, if this test shows that there's blood in the stool, then an individual will be called up to have what we call a colonoscopy or a telescope test to look in the bowel, usually at the bottom end, but potentially also at the top end. And detection of cancer when the only presentation is blood in the stool, which is only detected by special tests done in the laboratory, is more likely to achieve a cure. So moving on from there, so we've talked a lot about prevention, but I want to talk about treatment, and I'm going to talk about treatment as a whole. Treatment, no doubt, is always better in the early stages, because in the early stages, if it's a skin cancer, it could just be taken out. If it's a bowel cancer, it could be taken out. The breast, cervical, cervix, it could just be taken out. But when it starts progressing, then more things need to come in. We talk about treatments such as radiotherapy. We talk about treatments such as chemotherapy. Now, I will say there's one thing that transplant patients have the advantage of, particularly if they've got good kidney function. Often they can have all the treatment that the normal population have if they've got good kidney function and they are fit enough in other ways. Unfortunately, if an individual is on dialysis, for instance, many of the chemotherapies would not be available to that person because the kidney function wouldn't enable. And similarly, people who've got liver disease. So there are opportunities in terms of surgical intervention, chemotherapy, radiotherapy. And cancer treatment actually is getting better and better. And most centres will put people with cancers in for trials, research trials, and where there's an opportunity for that, I do encourage people to go into them. One of the reasons for it is because it may give people the opportunity to use a medication that may not have been available to them otherwise, or maybe is available in, say, the United States, but isn't necessarily available in the UK. So I've talked quite a lot about cancer, almost in a kind of, we've talked about epidemiology, we've talked about causes, we've talked about types, we've talked about treatments. But I think we can't really talk about the big C without talking about some other dimensions to it. And one of them is the psychological impact of cancer, the emotional, overwhelming nature of that diagnosis. Even if people only have a mild cancer, like a lesion on the skin that can be resected, it can cause a lot of distress. And that's why I want to mention to you some of the services that are available that people should try and tap into. And even if you're not asked, or even if it's not offered to you, you can ask for yourself. Now, one of these is psychological support. So most renal units nowadays will have a psychologist attached to them. And I can't emphasize enough how beneficial just sometimes talking to people can be. Because some things you might not want to share with your family, you might not want to share with your friends, but you could talk to someone who is completely independent and your conversation would be held confidential. And also, they can share with you different kinds of coping strategies to get through this diagnosis. There are other support networks, such as we have the Macmillan nurses, for instance, who form another tangible support network. Other areas where we can get support, and we shouldn't forget our families and friends, because often a time they're the ones spending the most time with them. But also, if you have questions, do ask your clinicians, do ask your transplant nurses and transplant consultants, because often a time, I mean, it's not an easy situation for either party, but often a time they don't know the precise questions that you as an individual have. So do feel free to talk to them, ask questions, ask for support. Another area that cancer can impact is on our finances, because people won't be able to go to work, they're getting symptoms that just don't enable them to do what they usually do, or they're taking time out to have chemotherapy and various treatments. And so finances, finding out what can be done through our GP services, through social services. There are forms, there are societies, Kidney Care UK, that can help provide grants, support to people. So do remember that you should try to tap into these. Now, just before I close, because we're talking about the big C, cancer, I just want to share with you a few symptoms that sometimes can mean that actually a closer look needs to be taken to make sure to see what is going on with you as an individual. I've mentioned lifestyle. Lifestyle, if we can, completely cutting out smoking, because it's a harbinger of cancer. And also, unfortunately, it shortens the lifespan of the transplant because it narrows the vessels and all the small vessels within the transplant that provide the blood supply, because of what it lays down and the nicotine causing constriction. So smoking, excess alcohol, because it's been proven nowadays that alcohol can cause cancer of the tongue and the lining of the mouth. Also remember, if you're using a mouthwash, use the alcohol-free version. And then diet. Diet is paramount, because without a shadow of a doubt, even though we know that with a transplant, your immune system is compromised, but if you don't have a good diet, it's compromised all the more. So remember to get a healthy diet, which needs to include, in addition to the protein, the carbohydrate, needs to include fruit and vegetables. Make sure your vitamin levels are adequate. And these are things that will be tested in your various centers. And then, what are some symptoms of cancer? Things like loss of appetite, loss of weight despite having an adequate, healthy diet. Things like excessive tiredness, and sometimes actually noting a swelling or an ulcer or something abnormal. So what are my parting notes to you all before we go into a time of questions? Cancer is not common, but it can occur. And yes, it is a bit more common among the transplant population when compared to the general population. Particular cancers that are perhaps a bit more common in the transplant individual are the skin cancers, and we've shared how we can prevent them, but also the lymphomas. And the other cancers can be more serious if not detected early because of the use of immunosuppression. So I'll stop here so that we've got the opportunity for questions, and I'll hand over to Hilary, our host.
Yeah, thank you very much, Joyce. That was really an informative session. I was just
Sorry, Hilary, I'm not sure they can hear you. You seem to be on mute.
Oh, no, I'm not on mute. I'm not on mute. Can you hear me? I'm not on mute. You can hear me? Okay, hold on. Can you hear me now?
While Hilary is trying to get back on. Okay.
Can you hear me?
Okay.
Yeah?
Can't hear you.
Wow. Okay. Well, someone said that they can hear me. I'll just put the question. Yes, they can hear me. They can hear me. So I'll just put the question on the screen. Okay. I'll put the question on the screen. Should there not be more education about the risk of the different kinds or types of cancer with patients?
So, can everybody hear me? Can you hear me?
Yes.
Okay. So, there's a question here. Should there not be more education about the risks of the different types of cancer with patients? So what I don't know is how much education is going on to each individual, but usually there are several levels at which, usually there are several levels at which education occurs. So points where the education takes place usually are in the clinics that we call the advanced kidney care clinic, where people's kidneys are starting to fail or to stop working adequately, and they're being prepared either for dialysis, a transplant, or all the pathways concomitantly. Another point where education ideally takes place is for those who have signed up and said, yes, I want to have a transplant. So often there are education sessions, and incorporated into these, there are discussions on cancer as well. And then at the point in time when one actually comes in for a transplant, ideally, once again, it's brought in. And then I'm afraid all the time that you're in the clinic, intermittently, there are sessions then. But sometimes it's not enough. And I just want to share with you some sources. And maybe, Hilary, if you haven't got these already, you can write them down. Mm-hmm. So the UK Kidney Association offers a lot of patient information. There's also Kidney Care UK that it's got very standard information. And most of you will have your hospital websites, and I can mention my hospital, St George's Kidney Patient website. And remember, you're very welcome to tap into different unit websites, because some might have one area that is stronger than another, and others areas that are stronger. And another resource are your transplant nurses and your transplant physicians. But actually, I'm going to take this question to my colleagues, because I meet at several levels. Like we have a London collaborative, we meet nationally. And I'll mention it that some patients would like more, and we'll look more objectively and make sure we're getting out adequately to you.
So the next question is this. If
immunosuppression causes or influences the risk of cancer after transplantation, how can this be mitigated to prevent the risk? How can it be mitigated is a good question. What we try to do is reduce the risk. So in the first instance, we want to give you the minimal amount of immunosuppression that you as an individual require. So that's the first instance. Constantly during your follow-up, this is part of what we're looking at. Is there any way we can reduce your immunosuppression further, but clearly not at the risk of you developing rejection? And then the other thing we're working through is, are there any potential signs of or symptoms, or with your blood tests, is there any potential that a malignancy of some form is developing? And then also we're encouraging you to get your regular screening tests. And I think my patients must get bored of me as I'm always asking, oh, how about your sunscreen? You're going on holiday, what about your sunscreen? Okay.
Yeah. Okay. So next one is how common
are transplant-related cancers? Now I'll tell you why that question is difficult to give a hard figure, because it keeps changing. On the one hand, because we're getting better with the use of immunosuppression, that's reducing the risk of cancers. But on the other hand, transplants and individuals are living longer and longer. I look after several patients who are in their 70s, so being older, we're more prone to cancer anyway. At the same time, I look after several kidney transplants that, they're one is over 50, others in their 40s, others are in their 30s. Now, the issue here is that these individuals will be on immunosuppression for all that time, and the longer one is on immunosuppression, the more likely of developing a cancer. Hence the need that even if one's 20, 30 years down the line and everything looks like it's going fine, still need monitoring. And so that's why I hesitate to give a blanket figure to you. But looking at renal registries, we can say that about 5%, maybe a bit more, may develop some form of cancer. But remember, majority of these cancers are going to be skin cancers, and they're in quote benign skin cancers that all you have to do is take it off and that's it. Okay. But because all of you are going to be using your sunscreen, that will be rare here. Okay.
Okay. So next question is how aggressive can the cancer treatment be?
How aggressive can the cancer treatment be? That's a good question. You don't want people to have more cancer treatment than they need, but you do want, where possible, to throw that cancer into remission. So let's define that a bit. Remember, it's at levels in terms of how you treat cancer. If it's just taking a little cancer out, that's not really aggressive, is it? If it's maybe doing some localized radiotherapy to a small area, that's not really aggressive, is it? Once we're moving on to more radical radiotherapy and more chemotherapy, then perhaps it is becoming more aggressive, but people are monitored when they're having this therapy to ensure that they don't get more than they can tolerate. Okay. Because with chemotherapy or radiotherapy or any cancer treatment, people then become prone to infections. And people can become really quite unwell. And so I work very closely with our oncologists and hemato-oncologists. Whenever I have a patient, I just take that patient under my care, and we're communicating constantly. So it's a joint effort. Now, in a way, having a transplant actually enables you as an individual to have more aggressive treatment, and I'll use that term, than say someone on dialysis, because you can tolerate the drugs. Mm-hmm. So in other words, if you've got a transplant, we have more of an opportunity of sending that cancer into remission in the event you need the more aggressive treatment. And at the moment, I have someone who's having some treatment for quite an aggressive cancer, but we can do that because they have excellent kidney function.
Okay. So the next
If
question.
people do develop cancer after transplant, can it be treated like normal cancer? So we've kind of talked about that, haven't we? That having a transplant, especially if one's got good kidney function, it often enables more aggressive treatment and often, in fact, treatments within the normal range. Although we are still aware that this is an individual on immunosuppression, part of the treatment that we sometimes do is actually reduce the immunosuppression they're on while they're on the chemotherapy, because the chemotherapy is a form of immunosuppression as well. And then there was a second part to that question I just wanted to tease out a little bit more.
Okay.
So how does that interact with the immunosuppressant the patient is on? So we've kind of answered that. So some of them actually duplicate. For instance, several people with transplants are on steroids. Part of chemotherapy is often very high dose steroids. So we might leave that off. There are some medications that do interact. This is why I, as a transplant physician, interact very closely with the oncologist, hematologist. So we're working in sync. Okay. So before they start any chemotherapy, they're on the phone and they're talking.
Okay.
Yeah. Okay. And are older patients more at risk of developing cancer? Yes, I'm afraid so. Why? When we get old, a lot of things start to go south, don't they? So it's, I'm afraid it's just one of those natural, because our immune systems, even when we're older, actually are not quite as strong as when we're younger, just like our muscles.
Yeah.
And yes, and in fact, some people say that, well, if we were to live forever, that our bodies would end up being riddled with cancers, as in cells going wrong. So I'm afraid so, yes, we are. Okay. Yes. Are there differences between deceased or living donation in the risk of developing cancer? Now that's an interesting question, and so with a living donor, okay, let me talk about donor factors.
Okay.
With a living donor kidney, have you noticed, I don't know if there are people in the room that have had living donations before, had a kidney from a living donor. The living donor undergoes such rigorous tests that some of them feel, do I really want to do this? Yes. It's the most thorough health check they'll ever get. And it's all on the NHS.
Yeah.
And so in that way, often if there is anything even lurking in the shape or way or form of a cancer, it can be detected early. By contrast, when it comes from a deceased donor, although there are checks, we haven't got all the history and everything that we've got with a live donor. Like if you're getting it from your brother, your sister, your mom, your dad, or your whoever. So that's one factor to bear in mind. It's uncommon either way, although both ways sometimes they do get cancers. But also, with a deceased donor kidney, is it more likely to develop cancer? Okay, let me answer this another way. If a kidney is not well matched, those individuals may be more likely to develop cancers in the future. And the reason being is the less good the match, potentially the more immunosuppression will be required. Yeah. For instance, sometimes if people don't have a ready match, we have to do what we call incompatible transplants, like ABO incompatible or HLA incompatible. And in order to achieve that, we have to give more immunosuppression. So because one has received more immunosuppression than average, that can predispose one to cancer more so. Okay. Renal patients receive periodic checks yearly for skin cancers. With these risks, shouldn't there be periodic checks for other types of cancer too? So yes, and a lot of these are already not only for transplant patients, but for everyone. So remember, when you get a transplant, it's not the time to divorce from your general practitioner. In fact, you want to embrace them all the more, because once again, this is another group of doctors that I tend to work in concert with, because I'm trusting that everybody that needs it will be getting their cervical screens.
Yeah.
Everybody will be getting their smears, their pap smears. Everyone will be getting their fecal occult blood testing. Everyone will be getting their mammogram. Everyone will have their, at 40 years, their health check, etc. So tap into those, and even more so, even if your friends who don't have transplants or your family who don't have transplants, encourage them to get theirs, but please certainly get your checkups. So there are checkups for all these things. And there are other checkups that we're doing in the transplant clinics as well that you might not realize when we do these blood tests, when we're assessing you, taking a history. Yeah.
Okay, thank you very much to you, Dr. Joyce, for coming out today. We've come to the end of the session, and once again, it has been an interesting 1 hour. I'm sure everybody will agree with me. So again, I'd like to thank Dr. Joyce for taking the time to speak to us about preventing and or managing post-transplant risk of cancer. It has been really, really informative, especially for me as a transplant patient. I hope everybody learned something today. I cannot end the session without thanking all of you who've been here today to listen and to ask questions. And those who sent their questions in, you've been really amazing in wanting to know more. As Dr. Joyce has said, please ask your clinicians questions if you have any concerns. There is no point suffering in silence and then things worsen and then nothing can be done about it. This hesitancy about talking to people is prevalent across board, including people on dialysis hoping for a second chance at life. Through people like you in this session today, as well as watching the replay, you can be that person who gives someone a second chance at life. As a community, we do not consider organ donation, but now is the time to think about it. I will encourage you to sign up to the organ donation register if you're in the UK. And if you cannot do this, there are other ways you can help. Volunteer to help raise awareness about organ donation. And also you can donate blood, which is very scarce right now during this Christmas period. The NHS BT has funded us to give funding to people to raise awareness about organ donation. So please, as you're here today, reach out to us. Let us know what what you would like to see. Tell us what the issues you're facing, or if you have a relative that has any issue with kidney disease. We're here to help. So until next month, December, when we would have a pharmacist who will come to talk about the different medication that transplant patients take. Thank you very much again for coming out. And thank you, Dr. Joyce. Really appreciate it. Thank you. Bye, everybody. Bye.
Okay, goodbye.